So moving on to the next talk by Dr. Kumar Ravi, who was ex-faculty and consultant of Sankar Netralaya, Kolkata, and now faculty at Netralayam. He'll be dealing with medical management, failure, and way out. Welcome, Dr. Ravi.
Thank you. Thank you, Dr. Vibhuti, for having me in this IC. And I will be discussing about medical management, failure, and way out. And I have little different kind of presentation. All my points which I have to discuss will be in case format. So I have no financial interest. Coming direct to the topic, first case. My patient was a 46-year-old male. He was a diagnosed case of primary open-angle glaucoma, and he was on 2 anti-glaucoma medications, prostaglandin analogs with combination. And he was on follow-up, and his IOP was 24 and 22 millimeters of mercury. But then the expected IOP was 16 millimeters of mercury. So why is he having high IOP? Is the medicine not working? So first important thing is to know about the compliance thing. The patient admitted that he missed drop thrice in last 1 month. But if we dig into it, okay, we'll come to know that the situation may be very different. There's an article which says that patient might have missed 24 to 25% of their prescribed drop. Okay, and this they have done via study. They have done a gyroscopic sensor they have attached to the drop, which measures whether the patient has picked up the drop, whether it has been tilted. That means they're trying to verify whether the patient has used a drop or no. And what they found was that the patient is telling that he has missed 3% of the times, probably he has missed the drop 24 to 25% of the times. So my patient might have not put the drop for maybe 1 week in last 1 month. And this is common story with most of our patients. So if the patient is not using drop, the drop is not going to work. So this is my first message. The commonest cause of medical therapy failure is poor compliance, and glaucoma drops don't work when not used. Coming to second case, again, this patient was a 39-year-old lady. She was referred for left eye trab. And at presentation, she had a high IOP of 22 millimeters of mercury on 3 anti-glaucoma medications. I have a disc drawing of this patient, which shows that left eye, the disc is definitely glaucomatous. And she was noted to have open angles in 2013. The patient is having high pressure on 3 medications. That means probably she will require a surgery. So before going for surgery, I thought of doing a full evaluation. Her pressure was definitely high. Disc asymmetry was present. But gonioscopy, there was 360-degree closure with few synechiae. And then it was opening with indentation, with deep indentation. So basically she required was first a YAG PI. I did YAG PI and observed her again after 1 week, and the pressures were normal. And after 1 week follow-up, now she's almost on 3 years follow-up, the pressures are normal after PI without any medication. So basically angle closure disease, medical management has a role, but that should be after PI. Once we have done PI, then many of the patients may not require medical management. Now a similar case, something similar to what we have seen in case 2. This was a 42-year-old male. He was seen in 2017. The pressures were high. He had a little bit of disc asymmetry, and YAG laser was done for angle closure glaucoma. But after YAG laser also, the patient was seen that IOP was going up in 1 week to 3 months. He required 4 anti-glaucoma medications to control the pressure, and the pressure is still high. So here we have a patient who has a YAG PI done, PI is patent, still pressure is high. That goes towards diagnosis of plateau iris syndrome. So if we have a patient with patent PI and high pressure, suspect plateau iris syndrome. And we have many postgraduate students probably here. So what would be the drug of choice when we have a plateau iris syndrome patient? So basically we have to give them pilocarpine. Okay, so it's a less commonly used drug nowadays. So for this patient, I started pilocarpine in OPD itself, and the pressure came down from 36 to 16 within few hours. So ultimately, we could reduce drops 1 by 1. And in the last follow-up last year, the patient is on single drop pilocarpine and is doing well. 10 years follow-up, field changes are virtually not there, almost stable fields. Now, correct diagnosis and drug of choice makes the difference. Coming to the next case, it's a 19-year-old young patient, very high pressures, was on maximum medication with tablet acetazolamide, with history of anti-uveitis in the past. Now, when we observe this patient, angles are open, CDR is okay, but pressures are very high. he told that some injection had been given to his eyes. Initially, we thought that probably anti-VEGF injection maybe for some reason has been given, but when we looked inside properly, we thought that we saw that it was subtenon steroid depot injection. So because of steroid-induced glaucoma, he had a very high IOP, and this was done bilaterally, so both eyes pressures were high. So if we have a patient of steroid-induced glaucoma, the first thing that we have to do is to remove the steroids. If the steroid, say in the form of depot or injection or tablets, if it is there, pressure will not come down whatever medications we use. In this case, one eye we removed surgically, and other eye with medication we could control, and slowly that steroid depot dissolved. So coming to the next case, this was a 59-year-old patient with high IOP on maximum medications again, with recent onset of redness in the left eye. There were no other history or complaints. So if you see this patient, left eye, there's a engorged blood vessels, and if you see carefully in the angles, you will see that the Schlem's canal has blood there, this area. So something more than a basic glaucoma. When we did imaging and detailed investigation, we found that she had keratoconus fistula, and the patient was referred for proper treatment of fistula, following which the glaucoma symptoms automatically resolved. Now, in unilateral high IOP with red eye, please suspect something else. It will not be just angle closure glaucoma or open angle glaucoma. It could be, say, traumatic glaucoma, CCF, or proliferative diabetic retinopathy changes leading to secondary glaucoma, or something will be there. Once we treat this underlying cause, the patient may require minimal medical therapy, or sometimes they do without therapy also. Without therapy also, the IOP is under control. Now, this is a very interesting case. This is a young boy, 12 years old. He had allergic conjunctivitis, and he was on long-term treatment with multiple therapy, and he was referred for glaucoma evaluation with the pressures of right eye 16 and left eye 2. It's not spelling mistake, it's actually 2 pressure. So when I evaluated again, I saw that yes, it is correct. Patient is having glaucomatous disc with IOP of 0. I was getting a pressure of 0. And treating doctor had withdrawn the anti-glaucoma medication 6 months back, thinking that this is not glaucoma, pressure is 0, how can it be glaucoma? We rechecked it, actually we're getting 0 pressure. Now if you see the pictures carefully, there is a central scar. So because of maybe shield ulcer or something, this patient had a central scar. And if you see the corneal curvature, the curvature was not the typical corneal curvature. There's a flattening over there. Because of this flattening in the corneal curvature, the pressures were coming as abnormal. With all instruments, we're getting abnormal pressure. But at least in these patients, we can do disc evaluation, we can do perimetry, and they were all suggestive of glaucoma. So my take on this is irregular corneas, we can get false pressure. This can be because of multiple reasons, maybe trauma, maybe some scar in the past. So IOP alone does not define glaucoma. We can do a proper disc evaluation and visual fields maybe 6 months or yearly, and then follow up this patient. This particular patient, we followed up on 2 anti-glaucoma medications, and the patient is stable. Now, coming to another case, 56-year-old male, he was having stable glaucoma with pressures in the range of 16 to 19 and was stable for last 6 months. But in one particular follow-up, the pressure shot up to 24 and 26. This can happen in our glaucoma patients. Like say if you have 100 patients following up for glaucoma, 1 or 2 patients may actually show progression even on the stable therapy that we are using. So the patient had borderline IOP. We kept him on close follow-up, but we need to add medications in these patients because they can be a slow drift, especially seen in beta blockers, but in other medical therapy also there can be a slow drift in IOP. In some cases we need to add medication, but remember that when we are adding medications, they can be non-responder. The patient may not respond to therapy. Suppose we add anti-glaucoma medication over and above the one that we're using now, say at the pressure of 26. And in follow-up, we see that the pressure is again 26 or 27. That means the drop we have added is not working. So we need to look into alternatives. Now coming to another interesting case, 46-year-old patient diagnosed with angle closure. He was started on anti-glaucoma medications after PI and was started on brimonidine. This is a very unusual case. Okay, may not see day-to-day basis in clinic, but yes. After starting brimonidine, he's developed AC reaction, cells and flare. This is a very uncommon thing, but anti-glaucoma medication sometimes can cause AC reactions, and this was causing increased pressure. Initial pressure was 26, and after starting therapy, it was 38. So there are instances when glaucoma medication itself can induce high pressure, but these are rare instances. Now, all medications have side effects, and we have to select one that we require with tolerable side effects. Then there are a group of patients, mixed bag cases, like say congenital glaucoma or lens-induced glaucoma, in which let us not go into the medical management. These are all direct surgical cases. Towards the end of the presentation, medical therapy doesn't work if patient misses drop, if we miss a diagnosis, if there is a improper follow-up of IOP and HVF. Glaucoma is usually a slow progressing disease. It will give us multiple opportunities to take corrective measures, and we should be prompt in picking up time for intervention. The take-home message: medical therapy of glaucoma needs us to ensure patient compliance, not miss annual GONIO 4 to 6 monthly checkup, and disc and field evaluation. Glaucoma offers multiple opportunity for course correction, and we need to pick up the signs and then switch as and when required. Thank you.
Thank you, Dr. Kumar Ravi, for this wonderful bouquet of interesting cases, and that has conveyed the message when we have to look at the failures. So if failure occurs during the course of treatment, then we have to revisit our diagnosis. We have to revisit the compliance issues of the patient, and also any other changes which are developing, newer things developing into the patient that need to be taken into consideration. We'll have questions later on. So we move on.